Good evening. My name is Pauline Berger, and I'm the GENiDA project manager. And first of all, I would like to apologize for not being with you tonight. I will speak about the GENiDA participatory database that was created in France back in 2016 by Jean-Louis Mandel. It's an international participatory patient registry about the manifestation and the natural history of genetic forms of intellectual disability, together with autism and epilepsy. The purpose of this registry is to accelerate knowledge on genetic forms of ID and to, in fine, improve patient care and families' information. The website is dedicated to people concerned and their families, but also to doctors, researchers, and any health professionals involved in the management and the care of the disease. The project was funded by the University of Strasbourg here in France, and we also got other fundings towards the years. We collaborate with national and international patients and families association, and we have a scientific advisory board that meets annually by the time of the conference of the European Society of Human Genetics. Here you have a picture of this gathering last month in Berlin. So GENiDA mainly consists in an online questionnaire that is currently available in 8 languages, and soon it will be translated into Turkish, Romanian, and Bulgarian when our new website will be put online by next fall. It consists of 46 major questions, mainly MCQs, and also 5 free text questions and open-ended comments. We are collecting information about medical problems, behavior problems, quality of life, adverse effects of medication, and so on. The questionnaire is meant to be completed by the affected person if she's able to do so, or by her parents or caregivers. And of course, the data anonymized. So we are recruiting patients mainly by direct contact with national and international patients association. We have flyers that are already translated in 10 languages that present the registry, some facts and figures about the project, and also what kind of data can be collected and what can be done with those data. We also have some posters dedicated for clinicians' waiting rooms and rare disease centers. And of course, we are present on the social networks, mainly Facebook and Instagram, quite recently, to recruit more and more patients in various cohorts. And as I said, we are also collaborating with professionals that have access to the data, and then that can submit additional specific questions to subsets of patients or cohorts. They can recruit patients for ethically approved research projects and clinical studies, and they, of course, can generate medically significant knowledge based on the data analysis that can then be translated into publications in scientific journals, or that can help to improve patient management and families and information via the drafting of clinical practice guidelines, or what is called PNDS in France, for Protocoles Nationaux de Diagnostic et de Soins. The data collected by GENiDA have already been used in several PNDS or are currently used to draft some clinical guidelines that are in preparation for Kleefstra syndrome or for KBG syndrome, for instance. So some facts about GENiDA. We have almost 2,000 participants already that have filled the questionnaire. This represents more than 60 nationalities, and 250 professionals have access to the data for the moment, either to a specific cohort or to the whole data collected for GENiDA, all cohorts included. And here you have some examples of our cohorts and the participation in these cohorts. So the two main ones are Coulon-de-Vries syndrome and Kleefstra syndromes, which are kind of historical cohorts in GENiDA because they were started at the very beginning of GENiDA, and Dr. Coulon and Dr. Kleefstra were involved both in the drafting of the questionnaire and in the recruitment of patients. That's why those cohorts developed so well. And we also have another whole lot of cohorts that are developing at their own pace, but with quite regular registrations. Regarding the CASK cohort, it developed well over the last year because in July 2023, we only had 3 files completed, and now we reached the number of 12, 11 French participants and 1 from the UK. And here is kind of an overview of the the data that we got. It's all the items present here are several questions that are asked in the questionnaire, and they are ranked every 24 hours from the most frequently reported by families to the least reported. So as you can see, walking problems or vision problems are quite often reported, contrary to problems to urogenital or vascular problems, for instance. And now in the next few slides, I would like to show you what we can do with data. And for this, I will speak about the Coulon-de-Vries syndrome, which, if you remember well, is our major cohort. KDVS is caused by either a deletion or a pathogenic variant in CONSOL1 gene. And the syndrome, the main features of the syndrome include ID, hypotonia, facial features, and so on. So by the time we froze the data in May 2022, the cohort consists of 237 participants with roughly similar ratio between women and men. But we had almost 200 persons presenting the deletion and only 40 with the pathogenic variant in CONSOL1. So the first question we wanted to address with David Coulon was to know if there was a difference between the phenotype of people with the deletion and people with the variant. And actually, there were no statistically significant difference between the deletion and the gene, the variant. We then had a closer look in the data that we collected, and something that was quite striking was the respiratory problems that were not really known by clinicians, no, by David Coulon, and that were actually reported as most frequently present in KDVS, and those problems were considered by families as a major issue in the daily life of the patient. And what is important to know is that by the time we put the question online for the first time in 2016, our respiratory problem question was not that complete and didn't mention infections or pneumonia. But we gathered the information through the open-ended comments. Here you have some examples with a variety of languages, and they were all talking about bronchiolitis or bronchitis that were quite recurrent. So these information are really important, and the reported respiratory problems were then considered as a medically new information and medically significant information. And now we have to understand the underlying mechanism to make proper recommendation for the prevention or the treatment of these comorbidities. We also had a closer look to epilepsy, and the frequency and the age of onset that are reported in the GENiDA data are consistent with what was already published about epilepsy in KDVS, but GENiDA provides further detailed information on the types of epilepsy found in people with KDVS. And we also studied the frequency of use of different anti-epileptic drugs, their perceived efficacy, and some associated side effects. And we had to recontact people. We collaborate with Nicole Coulot, an expert physician in pharmacovigilance. And the result of this study was that two most commonly used anti-epileptic were levetiracetam and valproate, with a trend toward a better efficacy and lower side effects for valproate. So these results were published last year, and they were published soon enough to be included in the guidelines that were drafted by the end of 2023 in France. As I said, clinicians can also use GENiDA to ask new sets of questions to cohorts, to dive further into a specific problem. And that was done by the team of Nijmegen in collaboration with us to understand and to characterize better the musculoskeletal problems associated with KDVS. To get better insight in these spinal deformities, we had to recontact people that already replied to GENiDA, and we also recontacted people included in the Radboud UMC Biobank in Nijmegen, and we spread the word towards the KDVS Foundation, the US association. We got 54 participants that accept to send medical records or to reply to a survey when the medical records were not available. And they also send spine X-rays and MRIs to Nijmegen for a retrospective review. And the main result of this study was that we showed that scoliosis prevalence in KDVS exceed by far the prevalence of scoliosis in the general population. And some recommendation for full standing spine radiographic screening have been done by the time of the KDVS diagnosis at the start of the growth spurt and also at the age of 18. Again, these results have been published and included in the clinical guidelines. And a second ancillary study has been undertaken together with a team in Israel to deepen insight on non-ophthalmological manifestation of KDVS. Our call for participation was available only in French and English, and in 6 months we got 67 replies from families that replied to an ocular survey and accepted to send their medical records, ophthalmic exams, clinical photographs, doctor visit summaries, and so on. And we confirmed some of the common findings associated with KDVS, including amblyopia, upper eyelid ptosis, and so on. But we also evidenced some association of the KDVS with rare retinal disorders or rare nasolacrimal disorders. These results were published, but a bit too late to be included in the clinical guidelines, and they will be in the next update of this PNDS. And this is my last slide, and I just wanted to let you know that we are also working with other registries, and we are now putting the interoperability with ILIAD, the meta-registry built in with IRN Ithaca in place. And to do so, to make your file in ILIAD and your file in GENiDA communicate, we need to generate a spider number, which is a pseudonymization tool. So we are now currently asking parents in GENiDA to give their consent for this interoperability. And if they do, we need the patient name and surname and the date of birth only to generate this spider number. And we started the consent collection in March this year, and we already have more than 500 consent collected. So I hope I did convince you of the GENiDA's usefulness. And the more data we have, the more accurate the information we can extract will be. And this will be beneficial for the preparation of the guidelines that are in discussion about CASK in France. And once this PNDS is written, it will be easily translatable into English and other languages. So here you have our contact details, our social networks. I want to thank GENiDA participants, the families and the patients and their families, the clinicians and researchers that are involved in the data's analysis, and you for your attention. Thank you again. Good evening.